Okay, hi everyone. We're going to get started. Thank you all so much for coming here today. It's really exciting to see a packed room. Welcome to the Opioid Crisis Management Training, also known as OCMT. This is through Missouri's State Targeted Response to the Opioid Crisis Grant, which hopefully you all have heard of by now, but you'll hear reference to it more throughout the day. So we have a really packed agenda for you, so I'm not going to waste any time. Giving you an overview of what to expect in the next 4 hours, we're going to start with large group presentations. So I'm going to talk to you for just a couple minutes, don't worry, and then we're going to hand it off to our experts who are going to walk us through state protocols, the medical aspects of opiate use disorder treatment, the counseling aspects, peer support, and then some administrative and implementation guidance. Then we're going to have our patient panel, people who are in recovery and can speak to the role of medication in their recovery and their lives. Then we're going to do breakout sessions by profession. So you can still switch, but you likely indicated this on your registration as either belonging to the medical breakout or the psychosocial or the administrative. So we'll give you updates on those, but the psychosocial group will be in this room. This is the largest group, and then the other two rooms are just behind us. And then after that, I urge you to stick around. It might be tempting to leave because there'll only be like 10 or 15 minutes left, but come back. Let's reconvene in this room just to touch base about the resources that are available to you, what else you want to see from this team and this grant and this region and this state, and then we'll say our goodbyes and maybe talk about some next steps. So I'm going to slow down a second. I also want to address a couple housekeeping things. One is that today is a very exciting day because we're filming this. There have been a lot of requests for people who can't make it to these long trainings, so everyone be on your best behavior. If you're going to ask a question, please do so. We really want this to be interactive. It can be informal. This should be conversational. Ask tough questions. Be honest. If something sounds crazy or like it's not going to work, please speak up. What I do ask is that you raise your hand only so that we can get a mic in front of you, and we have Anusha and Noel at the back who can run mics. Okay, other than that, bathrooms are out here. We're going to have some breaks in between, but then we're going to try to keep on schedule. So, why are we here? Why have there been 9 opioid summits throughout the state? Why did Missouri get $20 million to address the opioid crisis? Why is everyone talking about it? Why is it on NPR every time you turn on the radio? It's because people are dying. A lot of people are dying. And they're continuing to die despite our talk and our efforts and our money. So we got numbers from 2016. They were worse than 2015. The numbers for 2017, the few that we've seen, are not looking good. I'm sure you've heard the statistics that more people are dying per year than are dying of car accidents, than gun homicide, or that died on the American side through the entirety of the Vietnam War, or that died annually at the height of the HIV/AIDS epidemic. Something to also keep in mind is that this is a really conservative estimate, right? These are people who die of opioid overdose poisoning. This does not include people who die for reasons related to opioids that might not be acute overdose. We've been living in this extreme cold for the last couple weeks. What about people who are homeless who die of exposure because they're out on the streets because of their addiction? What about people who die of Hep C or AIDS because of infections related to injection drug use? Or people who die of injury from intoxication? We don't count any of these people in these numbers. So the problem is also much bigger than we realize. And even for every one fatal overdose that we have documented, it's reported that there are upwards of 30 non-fatal overdoses that occur that may or may not be tracked. People who are revived by naloxone or rescue breathing or may just get lucky and come out of it. So indeed, this is the biggest public health crisis of our time. and it's driven by these astounding death rates. So what are people dying of? This has changed over the course of the last decade. And indeed, our policy approaches cannot keep up with the changing face of this epidemic. So right now, people are dying of fentanyl, and then of heroin, and then of prescription opioids in that order. We're not going to go into the politics and the history of big pharma and prescribing. We're not doing that today. This is not a history lesson. Today is, what are we supposed to do about it? And right now, we need to know that fentanyl is indeed a very real threat on our streets because it's largely mixed in with the existing heroin supply. Sometimes users know about it, sometimes they don't. Sometimes people are seeking it out, oftentimes they're not. But regardless, it's 50 times stronger than heroin. That doesn't mean it gets you 50 times as high or it feels 50 times as good. It means it's 50 times as strong. And it takes that much less to kill you. Okay, so we're seeing people who may have been injecting heroin for decades out on the street without incident who are coming across fentanyl for the first time in their life and overdosing. So we don't need more fear mongering, right? We know that when we talk about drugs being scary, that doesn't necessarily work. At the same time, we do have to understand that the heroin that's out there today that's cut with fentanyl or the pure heroin is different than what it may have been when many of you who have been in this field for a really long time started your careers, right? And it changes the way we approach things as treatment providers because when we lose patients, when people slip through our grasp, the idea of a relapse is much scarier now because that very well could mean death. So how do we manage this opioid crisis? This is called the Opioid Crisis Management Training. First of all, we know we need to do things differently than we have been. When it comes to treatment of opiate use disorder, broadly speaking, nationally, we haven't had great success, right? That doesn't mean there's a lack of heart or a lack of will or a lack of effort, but it means that we've been treating it like other drug addictions, and we see the same sorts of things. We see revolving doors, people coming in and out of our treatment programs, right? People not staying engaged in treatment, people relapsing frequently and coming back, and us, maybe sometimes trying to put the same mold around a population that has a very different presentation. Now, I know I am likely preaching to the choir to many of you who are already well aware of this, who have already drastically changed your clinical protocols for how you treat OUD. But for those of you who haven't, or for those of you who are looking towards doing that, today is about getting that conversation going about how do we do this differently? And sometimes it might make us bristle, and it might not sit right, and it might not feel like how we're supposed to handle addiction. And yet, here we are, because we know that what we've been doing so far hasn't been working. We also know that we need to do it in ways that benefit and include all clients, all people who use drugs. So I'm talking both about type of drug use, so prescription pills versus injection heroin use versus injection fentanyl use. I'm talking about where you are, whether we're in St. Charles right now or whether we're in St. Louis City. And we're talking about socioeconomic status, and we're talking about race. We're definitely talking about race because we know that the face of this epidemic is different. It's whiter, and it's brought about a different response. Black communities have borne the brunt of drug epidemics in our society for as long as we can remember, yet without media attention or public dollars or this type of outcry, right? So it's excellent that we're taking a public health approach today, that we're using a compassionate stance, that we're talking about a disease, that we have a beautiful conference room, and all of us to talk to each other and learn. We just need to make sure that everybody in every community benefits from this approach this time, particularly our poor communities and our poor communities of color. We also know that we need to use methods that keep people alive first and foremost. So today you're going to hear a lot about using medication to treat opiate use disorder because it saves lives. You're also going to hear about naloxone, which you guys all got today. These are life-saving tools that we know we have in our arsenal. And no matter how determined we are, no matter how much we care, no matter how educated we are on other evidence-based practices, if our clients are dead, we can't apply any of that. So you're going to hear the phrase medication first as Missouri's STR go-to model, and that's where we're coming from. It's both logistically in terms of temporal order, getting people stabilized in medication, and it's also sort of in spirit, where our priorities should be for people with serious opiate use disorder. We also know that we need to manage this crisis with a lot of support. It's hard to do this work. Not only is it emotionally draining, but it can be complicated and there's a real learning curve, especially when it comes to talking about maintenance buprenorphine or low threshold Suboxone clinics or overdose education and naloxone distribution. These types of things we may not have learned in graduate school. We didn't learn in our training, right? So that's why we have this opportunity to talk to each other, to teach one another, to use as people to bounce ideas off of and get updated research, updated tactics and strategies about how to do this type of treatment. We know that we need to support each other. It's not something that we're all born knowing how to do. Okay, so lastly, I just want to go over some key assumptions. So we realize that getting into this area can be a little touchy. Right? It can feel divided. It can feel like an us versus them. But we don't have time for that, right? We don't need that. So let's all give each other the benefit of the doubt and agree on some common assumptions for today. The first assumption is that we all care. Every single person in this room cares, or you wouldn't be here, right? You wouldn't be in this line of work, first of all, and you wouldn't be dedicating your day to do this. You care not only about keeping people alive, obviously, right? But you also care about people achieving meaningful, fulfilled, well-rounded recovery. And too often, it feels like this is a debate where it's an either or, right? And today it's to talk about, no, that's a false choice. It can be both. We also need to assume that today we're talking about people with established opiate use disorder. Okay, so we all know what that is, right? Life is severely damaged. People are physically dependent. We are talking about the people who come to our clinics in withdrawals. Their lives have been upended. We're not talking about people who pop a pill every now and then or experiment on the weekends. Okay, so just so we're clear. And we're not talking about other drug addictions. We're not talking about crack or alcohol or meth or cocaine. We're talking about prescription pills, heroin, and fentanyl, just to clear up any confusion. We also can all agree that informed patient choice is critical throughout the treatment and recovery process. Now, two words are most important in that sentence: informed and choice. So when we say informed, that means that's our job, to inform our clients about all options that are available to them. And they can make an educated choice. This is not our choice to make for them, right? And choice means we need to listen and hear them. That doesn't always mean you automatically do whatever a client wants, because that's not medicine, right? But it means it's at least a dialogue and a discussion. We can also all agree that all people who are on some form of medication for opiate use disorder should be offered a wide range of psychosocial support services. This is not, here, take a pill, everything's going to be better. This is not a cure, right? Just because we're talking a lot about buprenorphine and methadone and naltrexone does not mean those things alone can get us out of this crisis, right? People have complex needs, high needs. We don't have to tell you guys that, right? Shelter, jobs, domestic violence, histories of trauma. We need to provide transportation and daycare and all the wraparound services that you guys are all pros at already providing. These are absolutely a part of people's well-rounded recovery, okay? And they should be offered at every turn. Whether they should be mandated is a different story, and that's where things get a little sticky. And lastly, we can all agree that people should have access to any service that benefits them for as long as it's benefiting them. No more arbitrary time limits, no more forced phases of treatment, right? Or cutoff dates or mandatory step downs or this or that, right? Wouldn't it be great if we could all have access to things that are working for us for as long as they're working? Okay. I'm going to hand it off now to Dr. Angeline Stanislaus. She's the Chief Medical Officer for Adult Treatment through the Missouri Department of Mental Health. She's a real leader in our field, and she's going to tell us what's what. Thank you.
Thank you. Good afternoon. Thanks for being here. So I can assure you there's hardly anyone in this room who does not know someone who's lost a loved one to opioid use disorder, from opioid death. It may be a patient we see patients who have lost a loved one, and we are trying to help them through grief. We also suddenly see people we work with, staff we work with, who now are grandparents looking towards retirement, becoming parents because they've lost their adult children. This is a common encounter. I would say think it only happens once, but it was very surprising how often I had encountered this in my job. So this is everywhere. It affects everyone. It does not exclude anyone. So how many people are dying every day from overdoses or anything related to opioid use disorders, from opioid overdoses? 130 Americans die every day from an opioid overdose, which includes a heroin, opioid pills or painkillers, and fentanyl. How does St. Charles County fare in it? This is the kind of the graph that shows. Let me see if this works. So the top line is St. Louis County. If you look at it, it's up. The next one is St. Louis City. Then you have the three lines of this. We have St. Charles County, which is the one in maroon or the dark red, and you can see it is going up. So pretty much the third county in the state where where you're losing people to opioid overdoses. So we had between 2012 and 2016, 260 deaths, which puts it at a rate of 13.69 for 100,000 people. That's pretty high. There's another way of looking at it. So we are looking at deaths, but what is the mortality or morbidity? What is the sickness or the illness that takes people for opioid use disorders into our hospitals? When you look at that, it could be an overdose, it could be, and if you look at the individuals, of admission and discharges from the hospitals. Again, the top one is St. Louis County and then St. Louis City, and then you have Jackson County, which is actually a pretty urban area, but then you have St. Charles County coming up, creeping up. So you have a lot more admissions going to ER, getting admitted related to opioid use disorders. Sorry. The next one is for our emergency room. Again, we see there's an increase in our residents from St. Charles County presenting to the emergency room for services. So not only deaths, there's also an increased level of morbidity related to opioid use disorders. So this is the number of people who are rescued by naloxone from January to September of 2017, administered by the St. Charles County ambulance after an opioid overdose. Now what's interesting in this number is 358, they rescued them. Many of them within the next 6 years, that are 6 times higher to die of another opioid overdose within the next year. So it is very high that these individuals may have been saved that one time, but that does not guarantee they are going to live unless we intervene. And this is what this talk is about. It is saving lives, intervening, keeping them alive, and joining them to the road of recovery, which takes years and years and multiple falls before we get to that point. So this is important to know. Once an individual, no matter what the best treatment out there in the world could be, once they're dead, there's no recovery. So there is a lot of conversations again, what is the best way to manage them? What about this? What about that? The bottom line is we have to keep them alive if they are to go on the road of recovery. And this talk is all about how do we prevent deaths. So from the Department of Mental Health, we have looked deeply at the statistics and then looked at the previous way of managing our patients versus what we need to do differently. And as I was researching, as part of it, this is a study from 2003. This was a Swedish study where there was a group of treatment providers who was asking the Swedish government for money in order to start a Suboxone clinic. And this is from 2003. And the Swedish government said, show us the evidence that Suboxone is better than intensive outpatient treatment. So they had only 40 patients. They divided them to two groups. One of them went into intensive outpatient treatment alone, and another group went into intensive outpatient treatment along with prescription of Suboxone or buprenorphine. And you will see that individuals who actually were just on the intensive outpatient treatment, that they dropped fairly quickly within the first 2 months, within actually 50 to 60 days. You see them drop. Over here, the attrition rate was much slower. But that is not what is important in this slide. About 20% of those who dropped out died. So it is not about abstinence. So when you're looking at people who were abstinent or who did not die, but were still using it, but they were still alive. But the ones who did not were only given with intensive outpatient treatment, 20% of them died. So what have we been doing so far that has really not produced the effect? I mean, we have been providing substance use treatment for years. This is not new. This is not the first time you're offering treatment. But why is it not working? What are we missing here? The first thing is we have always stuck to a detoxification model of treatment, meaning that we give medications just to decrease the initial withdrawal phase, and then we expect the psychosocial treatments or intensive therapy to take over, and they just have to pull themselves by the bootstraps and do what they need to do and get on the road of recovery. Does that work? For a few, it does work. There are several individuals who will tell you that is how they went to recovery. But for most, or a good number, it's not working. And it's not that it's not working, they're dying. The second thing was over-reliance on residential and group therapy as a treatment. I can tell you from departmental health required so many hours of treatment a day for so many weeks in order to get financially reimbursed for services. So we had patients who were doing 5-6 hours of group every day for weeks on end without any good outcome. So we really had to re-examine, do they need psychosocial treatment? Yes. But is it actually much more evidence-based? Are we really providing evidence-based treatment? And so we also found that many of these individuals were provided residential treatment. So they go in for 21 days, they're given treatment, they either have a detoxification or they go through that period of withdrawal, engage in group therapy. 21 days later, they're out. And guess what? Within the week, they were all we started. So we had this revolving door going over and over for years. So obviously, this needs to change. And the third thing was using treatment for opioid use disorder more as an acute model of care. When I say acute, let's say that A patient comes in with diabetic ketoacidosis, meaning the blood sugar has gone so high that the body is not able to use the sugar anymore, so it is starting to use the ketones in the body. They come into the ER, Dr. Rotnick or one of the other physicians sees them, gives them what they need to get their blood sugar down, and then says goodbye. That'll be acute care. We just took care of what that acute need was at that time. But is that going to really help this patient stay in treatment or do better in the long run? No, in order for that, you need to manage his diabetes on the long run and provide services that will help this patient manage his blood sugar better. So that is the paradigm we're switching to. A person who takes an overdose or who has an opioid use disorder comes to a physician, and they treat them with some medication in a short time just to manage the withdrawal symptoms, and then say goodbye. Now you go through psychosocial treatment and you manage it. Oppose that to really looking at what does this patient need? What support does this patient need? Would medication management going to keep this patient stable for a long period of time? So having that conversation with the patient, making that decision, that is what chronic care model means. So we are really switching from an acute care model to a chronic care model, meaning providing the care the patient needs as long as they need. And the fourth thing is, even though medications such as buprenorphine, it's another word is Suboxone, or methadone, have been available for a very long time, these were medications that were shunned. They were kind of looked at, why am I giving something, another opioid for an opioid use disorder? How does that work? But in reality, research after research has shown that individuals who have been prescribed a medication, such as buprenorphine or methadone, for the long run, they are able to maintain and even attain recovery in the long run. Whereas those without treatment, without that medication treatment, relapse faster. Not only relapsing, as I said earlier, there's also the risk of death. So one of the things we had to do was really redefine treatment success. Until this point, we have redefined treatment as abstinence. This abstinence-only model has been difficult. Patients they fall off the wagon, they get back on, and this bumpy road, but we still have to see how many steps are they moving forward, rather than stopping to count once they start taking some substance. So we had to really redefine treatment success as survival, which means staying alive. The second measure of success is actually recovery, which means going and having a life, just like everybody wants a life. Able to have your children, able to have a roof over your head, having meaning in your life, having meaningful relationships, because these are individuals who are shunned by the society, by the family, by the legal system. So really getting them back into having a life. So that is the second part. So we are calling this model as a medication-first model. That does not mean that these patients need medications only. They need the support services also that take them on the road of recovery. But you need to give medications first, because until this point, medications are only given for individuals who relapsed and relapsed and relapsed. They were never thought as a first line of treatment for this condition. So that's the reason why we call it medication first. Not to mean that it's only medication, but it's just to make that so it sticks in people's mind that they do not have to fail in order to be on medications. So what's the advantage of that? Anybody who's worked with individuals with opioid use disorders know how horrible the withdrawal feels. There is one of the people, if you hear them talk, they'll say, flu times 100, plus you've been hit by a car. That's how bad they feel. They cannot get up, they cannot function. And by giving these medications, we're able to help them not have the withdrawal symptoms and feel physically better soon. So it does relieve the withdrawal symptoms. So when a person who's in withdrawal cannot think clear, so what it does, it stabilizes the patient. The second part of opioid use disorder is craving. The craving is so intense. And if you don't take care of the craving, the relapse rate is very, very high. So having an amount of a medication, an agonist, such as Suboxone or methadone, in the brain, it actually helps suppress craving. And next, it also creates a mental ability for the patient to engage and benefit from psychosocial treatments, which then translates into retention, which then decreases deaths from overdose and increases recovery. So the key of treatment is retention in treatment. Research after research shows the longer a person is retained in treatment, the better they do and better is their survival and the increased chance of them recovering. So one of the things that whenever we talk about medication first model, the concern has been, what if the patient is selling his medication? What if the patient is diverting it? What he doesn't come back after I give him a prescription? And what if what do you mean by their psychosocial needs have to be met immediately? If you don't give them psychosocial treatment at the onset, how is it treatment? The answer is that typically a medication such as, like if it's methadone, it's only given once a day. Like every day they have to go and get it, which is quite restrictive in its way, but also decreases diversion. Second thing, with a medicine like Suboxone or buprenorphine, they're given on a weekly basis, sometimes twice a week, depending on. So that decreases the risk of diversion. So there's an inbuilt, there are inbuilt ways of decreasing diversion into this treatment model. The next one is also remember, if someone is trying, it's very rare that individuals go and buy Suboxone off the street to get high. If you want to get high, you want to go and get your heroin, which kind of is not without a ceiling effect. It just lights up all the bulbs together, right? So you're not going to go and spend your money buying Suboxone. So most of them buy Suboxone because they try it out in the community before coming to their doctor or seeing their therapist and asking it about it. So psychosocial needs, again, remember these individuals, when they're withdrawing, you cannot really get them into any kind of meaningful psychosocial treatment. So they have to wait a little bit before they get into it. So one of the things that DMH looked at is some of the barriers we looked at across the state as we were implementing this program was that there was lack of data to 1,000 waived prescribers. That means in order for physicians to prescribe Suboxone or buprenorphine, they have to go through 8 hours of training, a specialized training, and get another DA number. So we have given multiple trainings across the state and continue to do so. If you're part of our opioid STR listserv, you can get notifications of when these trainings occur. But they do occur at least 1 or 2 a month across the state. The other issue was doctors may have the ability to prescribe, but they don't feel confident and they don't feel competent to manage. And they don't want to touch something they don't feel comfortable. I mean, I wouldn't want to do something I don't feel comfortable. So one of the things we are doing as a team, the OCMT, or the Opioid Crisis Management Team, is we are going from each agency, each region, to give trainings and provide hands-on training to the physicians so they feel comfortable and able to prescribe and provide the treatment. And also we have an ECHO, which is a telepsych service, which is kind of a consultative service where people it's about twice a month, they can join us and present cases and ask questions, and we also have a brief didactic. That's another way of community engagement. And also we are developing a database regionally so that we know which doctors are licensed, who have the special license, who can prescribe, and how could patients go to those practitioners. Again, we talked about switching from a detoxification model to maintenance model of treatment. The main thing is we're also developing guidelines based on empirically proven data. And we talked about the acute care model to a chronic care model, and also management of withdrawal symptoms and craving. The main focus is managing withdrawal symptoms and craving. And if you manage both, the relapse rate is much less, and you're going to retain them in treatment. So the other barrier we saw was when we went around the state, looking at the state of affairs at the time, was that a lot of physicians would start somebody on Suboxone and use a detoxification model, meaning they'll give like maybe for a month the most, or they'll 10 days, I've heard 2-week regimes, I've heard 21-day regimes, I've had a month regime. So they would put them on the medication and then taper them very quickly over a month period and say, now you manage it through psychosocial treatment. So this is this slide shows that there is no point in time limiting treatment. They have to need, it's like telling a diabetic you can take only insulin for the first 1 month or 2 months, and then that's all. And then you have to find a way to manage your blood sugar. If they need it, they need it. And let me finish it, and then we can talk about, ask questions. And so we found that this study shows that every time the maintenance they came off of it, the relapse increased. So one of the key principles of treatment that we're moving towards is, number one, medication should not be stopped unless it's worsening the patient's condition. Don't put too many barriers and say, we cannot give you medications. And the other thing we know is longer the patients have been staying in treatment, longer the retention, higher the chance of recovery, and more important than everything, decreased death. We are also making access a little bit more easier. As I said, the medication first model is a way to do that. There's some funding for telehealth equipment, meaning that doctors or doctors could use telehealth to treat some of these patients. And we're also, once they're stabilized, they do not have to get their prescriptions weekly. They can go into a little bit longer, maybe 2 weeks, over a period of time, or 6 months or a year in treatment. They can go to once a month. It all depends on how the patient and the doctor's relationship and how well they're doing. We also are tailoring the psychosocial treatments more to the need of the patient rather than a cookie cutter. Everybody, no matter what you have, you come in, you're going to get the 6 hours of treatment or 6 hours of therapy group, which hasn't worked. So really identifying what skill sets does this patient need and work on it. It may be parenting skills, it may be job finding skills, it may be a trauma they've experienced, but find what the patient needs and provide the treatment. And also, we are also encouraging local partnerships with the federally qualified health centers, other opioid treatment programs, and even community providers, so these patients could be maintained in the long run in the community. Thank you. Next, I would like to invite Dr. Fred Rotnick. He's a professor in St. Louis University. He is also the director of the community medicine program in St. Louis University and the medical director of the PA program, a physician assistant program.
It's an absolute pleasure to be here today, and all the people sitting at this table here are all part of the team, and we all know that some of the best conversations that we have at conferences are during breaks, so hunt us down and ask questions, because though we're here for a while today, it's not as long as we would like to be here. Also, anybody here at the St. Louis City Opioid Summit last month? Okay, a few. I get a little whooped up when I talk about this stuff, so just be warned. My clinical practice, 6 years of homeless health care, followed by 15 years as medical director of St. Louis County Jail and Juvenile Detention. There's some familiar faces here, I won't call you out. But I also, as has been brought up before, am tired of seeing people die left and right, and we need to do better. So we'll take a look at a couple things today in terms of the science behind the medications. And the reason, again, medication first model. I get really tired of people talking about you're substituting one drug for another. Okay, insulin's been brought up. We never tell people who need insulin, you're just taking drugs because you can't control your weight or your diet or your genetics, right? This is the slide I love because if you look at the green zone, the white zone, the red zone, green zone, euphoria, okay? White zone, normal emotional state. Red zone is a withdrawal state, which is just generally miserable, like we talked about already. Anybody in the room who's opioid naive and took opioids, any kind of opioids, assuming you don't overdose, will get a little bit of euphoria, right? But over time, what happens is the chemistry in our system, mostly dopamine, and we all know it's all about brain structure, it's all about brain chemistry, it's all about neurotransmitters. We know that over time, you go from vacillating between normal and euphoric to tolerance and physical dependence. Anybody who's had anybody in their family, whether legally or illegal, using opioids, know this changes over time. What happens then is, ideally, we want to help people get from this vacillation between white and red to getting back into what we would call a euthymic or normal state, okay? There's lots of ways that can happen. Sometimes that happens with talk therapy, and that's great. But what the real challenge is right here. What happens right there? We know in a lot of the work that we've done in the last few decades that when people start using, at what age they start using, makes a difference. What they use at different ages makes a difference. Folks' genetics makes a difference. We've known this for decades. So we need to figure out, how do we help people get from this state back to this state? And that's where sometimes medication, and a lot of times, remember our ground rules at the beginning of our talk today. We're not talking about folks who may take a few pills on the weekend or may, quote unquote, recreationally use. We're talking about folks with use disorders. And how do we get folks back into this area? Many of you have seen this slide before where we talk about the three main medications that we use for opioid use disorder. And this is a nice, clear way. Naloxone or naltrexone, or Vivitrol, complete antagonist, blocks the receptors. I could take stuff today. I could take a Vivitrol shot today. I could use heroin today. I'd get no euphoric effect. I wouldn't go into that green zone. Okay. However, if people use buprenorphine or methadone, these are partial opioids or full opioids. There is a euphoric effect if you're opiate naive. If you are using and you take these meds, what this does is it helps move you from that red zone back into that white zone. Okay. Notice that the curve is a little different here for buprenorphine versus methadone. Methadone is a synthetic opioid, and there is a dose-related response, so people can overdose from methadone. Buprenorphine, taken by itself, very difficult to overdose on buprenorphine because there's what's called a ceiling effect, and that's one of the reasons we're talking more about it now. You can also look at this in terms of light bulbs. Everybody likes the light bulb slide. Here it is. Now it's gone. All right. Naltrexone. Been around a while. Pill form. Also Vivitrol, 28-day depot formulation. It works well as a relapse prevention tool, which is why best outcome studies for this have been people coming out of prison, out of jails where people have had time to get opioids out of their system, or people who have gone through extended stay rehabs, which are becoming rarer and rarer. Okay? It's a complete antagonist. Methadone, gold standard, been around a long time, since the 60s. Works great. We're going to talk about some of the nuts and bolts in using it later on, but it really pushes people back up into that white zone, gives them a good dopamine response. Now, buprenorphine, Suboxone Subutex. I have no stock in the company that makes buprenorphine, okay? We're not talking more about buprenorphine today because we're all thinking it's the be-all and end-all. There are advantages to buprenorphine, but more importantly, the people who are in the room today are more familiar with naltrexone and with methadone. That's why we're spending a bit more time talking about buprenorphine. Now, some advantages of it is that it comes in a few different ways. In terms of dosing, it creates that dopamine push. It gets you back into that white zone. And it works well in community-based programs. Because if we look at some of the practical considerations of these three different medications, methadone works well for a lot of people, but you gotta live near a methadone clinic or be able to get there every day, right? And we know there's not a whole lot of these opening up around the state. Okay. Naltrexone and bup can be prescribed by anybody. You do need to get a waiver. You go through waiver training to do buprenorphine for a physician, an NP or a PA. You're interested in your organization getting training? Talk to us at the table. We can get you that info. But the other thing too is what we call the induction dilemma. If people need to be opioid free for at least about 5 to 10 days to get started on naltrexone or on Vivitrol, or else it's just like doing a Narcan reversal. And I don't think any of us have the clinical skills to establish good rapport with a patient we just did a Narcan reversal on, okay? So there's the induction dilemma there. With buprenorphine, you can be a moderate state of withdrawal, and it brings you into this idea of what are the treatment phases, okay? Induction is when you get a patient in your office started on bup. It says on the slide here 2 to 4 days. Sometimes it can take up to a week to get that right dose of buprenorphine to get that person into the white zone on that slide. Or the easiest practical way to say it, to get the cravings under control, okay? And bup will help get those cravings under control because as a theme that we've been talking about, to get to the therapy, the helping people get to that point of flourishing for those other areas in their life to address, people can engage much better in therapy when they're not obsessed with their cravings. Stabilization, 6 to 8 weeks. This is when, again, your person's not experiencing the cravings, the withdrawal symptoms are under control. They're engaging in therapy that can help them move forward. And then maintenance. As Dr. Stanislaus mentioned, one of the big changes looking at how we treat folks today is there is no magic period of time that you use these meds and then you're off. We sometimes have artificially imposed a 6-month, a 1 year, a 2 year, whatever it is. We're not in such a big hurry anymore to push these out of the way and to get people off of meds. Special populations, can you use these meds with pregnant and postpartum women? Yes. Can you use these meds with people with psychiatric comorbidities? Yes. In fact, many of our folks will know in the room here that a lot of our folks with chronic use disorders for substances also have some underlying mental health issue. And we need to help, let's see what things fall out first before we end up with folks having 10 and 12 diagnoses, okay? Jail doctor here, right? I can't tell you how many times I've gotten medical records from somebody that's got 12 different diagnoses, but nothing on substance abuse until you ask folks about it, okay? Homeless folks, can you do MAT? Can you do meds for opioid use disorder for homeless folks? Yes, but it can be a little more challenging. Everyone who works with folks who have a background of homelessness knows relationship comes first. And sometimes putting the meds together with the relationship building is your most effective method. Adolescents also approved, these meds are approved for work with adolescents. So, and of course, check your drug side effects. Oh, I jumped right over pregnant women. We love pregnant women. Yes, pregnant women do extremely well on methadone and buprenorphine, usually the Subutex, the monotherapy, okay? And why? Because it gets the cravings under control. When pregnant women are dealing with cravings and with substance use, that's usually not good for them or the fetus, and certainly not good for the families. So we have very good outcomes with pregnant women being maintained on these meds through pregnancy and then postpartum. Again, therapists in the room realize you're not going to make a major change in your therapy until other things in people's lives have changed, right? Same thing as a way to put on that medication hat and figure out when you change medication therapy. Practical considerations. The DEA has better things to do than chase down people who are prescribing buprenorphine, okay? I am pleasantly surprised the more and more I interact with DEA agents. Remember, jail doc, I've had a pleasant experience, a few trials down at the Eagleton Courthouse, okay? They want to work with you. The DEA does not want people dying from overdose. They're supportive of people getting started on meds. anyone who's going to abuse their prescribing privileges is not going to bother coming to this talk today, okay? So there are things that have to be done when you prescribe bupe, just like for opioid treatment programs. There's guidelines, there are record keeping. It takes a village to do this work, okay? We'll have our practice management experts up here in a minute, and they'll talk a little bit more about that. The fastest way to burn out a prescriber is to make them do all the work themselves, okay? I teach interprofessional ed at St. Louis U, and the key to doing healthcare well is doing it as a team. And finally, follow up, end on this note. I like to give patient profiles as kind of a broad example for people who may not be that familiar with these medications on who does well on each of these meds. What might a successful patient profile look like? Vivian Vivitrol, we'll start with her, okay? Vivian Vivitrol had complications following a C-section. She's a charge nurse at one of our local hospitals, let's just say St. Louis U. And like every other good floor nurse, she's got a bad back. She broke part of her lumbar spine at one point, got started on Percocet, got surgery, but being a busy mom and nurse, she did not go to her PT appointments as recommended, got stuck on her Percocet, developed an addiction. Structured life, didn't have a history of opioid use disorder until she had a bad surgical outcome. She is somebody that might do extremely well on an antagonist like Vivitrol. Work with her therapist, coping skills. She may need to be on Vivitrol a few years, great. Let's compare that to somebody like Suboxone Sam. Started in his parents' wet bar at 14, drinking some vodka. Got onto pill heroin on the playground at 17. Ended up in detention. He's somebody who started using at an early age when his brain chemistry and his brain structure was still very malleable. His neurotransmitters may not work well ever. This is something we're learning. Start using early. We know that brains aren't fully developed until about 25. Suboxone Sam lives in Jefferson County or St. Charles County. He's got a primary care doc who can get him on Suboxone. Cravings are under control. He does well. Now let's talk about Methadone Marty. He's been in and out of my shop in my Clayton office, as I like to call it, at the jail in Clayton. And he failed a couple trials of buprenorphine and Vivitrol because he started using early, just like Sam did, but he could not get the right response or enough of a response with Suboxone. He needed to get that biggest push that he could of dopamine from methadone. He's able to get to the methadone clinic. It works well. So, questions? Yes, sir.
I say, what about money? A lot of my clients have no insurance or just Medicaid, and there's just so much limits as to how much insurance money they have available for medication management.
Thank you. Money is always a good question. Part of our opioid state targeted response funding is going to direct services. 76% has to go to treatment and recovery support. And you say, well, that's 2 years. Well, yes, it's 2 years. But the goal of the work that we're doing, all our buckets in our great diagrams that we have here, our goal is to change systems so that we can get better reimbursement, change how we do Medicaid, how we do Medicare, so that we have the data to show that this works. And that's something that Rachel and her team have done a phenomenal job with, is having a strong evaluation component, so we're showing that this works.
That's all fantastic, and I agree with everything Dr. Fred said, but you're absolutely right. For people who don't have insurance, how do we pay for health care? This is not an issue relegated to MAT, right? This is our entire system. Where do these people go? How do we provide long-term preventative medicine and well-rounded chronic care? That's really hard to find. So Department of Mental Health in Missouri has the block grant. So forget about this STR grant for a second. DMH and DMH substance use treatment programs treat the Medicaid and uninsured population. They got lines around the block, right? It's really hard. There's not a ton of capacity. There's not a ton of funding for this federally or statewide. So there's no magic bullet. The STR grant is helping. All our direct service reimbursement goes strictly to people who don't have insurance or who are underinsured. But you bring up a fantastic, horrible problem, because especially if you're not in a DMH addiction treatment program system and you're at an FQHC or you're a hospital or a community provider, you might not have a big bucket of charitable care money that you can use to treat uninsured people. So don't mean to be a downer, but you're absolutely right. And, this comes to a broader question of healthcare access for people who can't afford it.
Well, thank you, Debbie Downer. So, but if we weren't hopeful people, we would not be in this work, right? What are the alternatives? Do you have a question?
I just wanted to comment that as an RN who does a lot of the assisting with our physician who prescribes Medicaid and Medicare, we've had no problems with them covering medication-assisted treatment. Every once in a while, you may have to call and do a prior authorization, but other than that, we've had no resistance at all.
Thank you. Okay. Our next speaker today is Ned Presnell, who is Executive Director at Clayton Behavioral Health, and the man who will talk about the role of counseling in a medication-first model.
So how many of you are counselors doing direct practice? So probably most of the room, or a good portion of the room. And so it might seem odd to ask the question, what is the counselor's role in a medication-first paradigm? But we actually have a really huge role. If you work in an agency that's anything like mine, we spend the most time with patients. We develop the longer relationships with them. Doctors don't have as much time to spend with them. And they listen to us about a lot of things. We only can give so much information about medication, but we have to. I mean, just last week, I educated someone who was untreated bipolar on the opportunity to get medication, how it might affect that illness, went in and got medication, and then did better. So we play a really important role in both the medication side of treatment and also with the other interventions we do. I want you all to read this quote. I won't read it to you. This is from Kevin McCauley. He was a physician himself who had an addiction to prescription opioids and ended up being court-martialed and sent to prison, where he read every book he could find on addiction. He became one of the spokespersons for the disease model of addiction, really when it was first coming into vogue. Craving is suffering. Craving is not pleasure-seeking. This past weekend, my daughter, she was 4 years old, had her first sleepover. And she was just dying to do this. She kept asking me, Dad, can Hattie come over? Can Hattie come over? Hattie is her 4.5-year-old cousin. And so I said, okay. And so I called up the uncle and aunt. And Hattie was super excited. And she came over, and we played games, et cetera, et cetera. And then it came to bedtime, and Paige crashed out in her bed. She was tired from all the fun. And Hattie sat in her sleeping bag and was almost hyperventilating. She was so nervous to be at someone else's house. And she started obsessing on Mom, I need my mom, I need my mom, I need my mom. And she came downstairs, my wife came downstairs and said, this isn't happening. There's no way Hattie's sleeping here. So I said, all right, I'll get in the car, drive her home. We know from neuroscience that the part of the brain that addiction affects through the course of the illness, when it becomes a serious attachment in people's lives, is the same part of the brain in which we form our fiercest attachments. And that's why all the emotional responses people have to addiction when they're trying to separate from the drug looks like separation from a major attachment that provides security in their lives, right? So there was nothing I was going to do to talk Hattie into not being distressed about separation from her mom. And truly, there is nothing. I mean, we've known this since the founders of methadone, the two developers of methadone. One was a physician, and one was a really renowned psychotherapist. And she said, "There's nothing I can do with talk therapy to help people long-term separate from heroin." This was back in the '60s. Words only go so far for a medical condition. Another way to think about it, if you think about the stages of addiction, is that there is pleasure seeking in the attraction phase of the attachment to drugs. But over time, the intensity of that drug use and the euphoria decreases, but the need for the drug increases. People are like, wow, that's strange. You know, the people are getting less and less out of the drug. If you ask someone who has been addicted for a long time, oh, you're really using to get high, huh? They look at you and they're like, I haven't been high in years. I'm just using to feel normal. How many of you have been married or in a partnership or some kind of relationship for more than 10 years? How about 20 years? 30 years? All right, I'll stop there. There's some long-termers. So all of you who have been in relationships, partnerships, marriage, had an animal for more than 10 years can tell me that it's just as hot and exciting today as it was in the first month. No, because the attraction, you know, nature needs to bring two strangers together. It needs this powerful form of attraction. But there's nothing that is as powerful for human beings as attachment. When people come into treatment for opioid addiction, which hits the attachment system in a very special way, they've been doing this for a long time generally, and they're not seeking euphoria anymore. It's become one of their fiercest attachments, and the attachment that provides them the greatest sense of security in the world. And so when we work with folks as counselors, our number one job is helping them separate and grieve the loss of the attachment. So I don't have a lot of time, so I'm gonna focus on 3 key aspects of counseling in a Medication First program. And the first one is, if you're in the counseling field on a regular basis, working with patients with opioid addiction, you're gonna face the stigma against medical treatment, against agonist, buprenorphine, and methadone treatment. You're gonna face your clients' experiences of discrimination for being on the medications, whether it's in a job or a housing facility or a treatment center, right? It might even be your treatment center. And so the first step is we need to challenge the stigma against agonist treatment. I'm going to give an example of that. We need to patiently accompany clients through the stages of grief. I'm going to get a clinical case example of that, and then help clients find security in other ways in the world. So the stigma against agonist treatment. Brandon is actually a family member in my wife's family. And I got to know him through interaction with his father, who recently passed away, but was 30 years sober from heroin addiction himself, and he used only AA. And I was actually interviewing his father about his recovery as part of a documentary series. And while I was talking to him as the example of someone who recovered using AA, he said, you know, I got to tell you about something else. I got to tell you about my son. My son's been struggling with heroin addiction for 10 years. And he said, first, you also have to know the heroin people are using today is not like the heroin I was using 30 years ago. And I see kids coming in and out of AA, and they're not getting well. And my son was just out of prison a few months ago, and he got out, and he got onto a buprenorphine maintenance program, a state-funded buprenorphine maintenance program out in Jeff City, run by Preferred. And when he went in there, he said, I just want detox, doc. I just want detoxification. I don't want to be on this medication. I don't want to be dependent on something else. And he said, I felt really proud of him for that. But then he got on the medication because he had a strong stigma being a kind of long-term 12-stepper against the medication. But then he got on the medication, and I saw his life change in a way that I had never seen before. He was calmer in that, being on that medication, than he had been since I could remember, and he started doing things he never did before. He started going to AA groups. He got a sponsor. He showed up when he said he was going to show up. He got back into school and got a certification to cut hair. You know, he got an apartment and paid for it by himself. I had my son back for the first time in a decade. And I talked to his mother, too, and his mother said, you know, it was this radical change being on this medication. It was like the missing piece for him. So then Brandon came to his father after a couple months of being on the medication and being out in the world, and he said, Dad, you know, I'm taking my recovery really seriously, more serious than I've ever have. And some people in AA that I really respect a lot are telling me that I'm not really sober until I come off this medication. He'd actually had an NA sponsor who from the very beginning said, you got to get off the medication right away, you're not going to, or I'm not going to sponsor you, and really put his foot down. And he switched from NA to AA, where he got a little bit more acceptance, and he found a sponsor that was a bit more accepting. And then it became a kind of a softer stigma at that point, where, you know, it's okay for now, but you're sure going to be doing better if you got off it. He went to his counselor at the treatment program because he was conflicted about this. So this is the kind of thing that will happen to us. Someone will come to us and he'll say, I'm conflicted about this. These friends I have in AA, these people I really look up to, people who have a lot of time that I respect, are telling me that I'm going to be doing a lot better once I come off this medication. And he asked the counselor, what do you think? His mom actually related this to me later, and she said it because I couldn't believe it. His counselor said to him, well, as a person in recovery for 12 years, I don't like it. I do think you should come off of it. As your counselor, I think you should stay on it. Because the culture of treatment had started to change, and it was his responsibility to be part of the team. The doctor was prescribing the medication, told the guy that he should stay on it, and the counselor didn't really want to conflict with that, but he himself was torn. And this world is changing now. I think it's a lot better now, even than when STR started. We have a lot of education and cultures are changing, but it's still something we're going to face with patients. And it's really important for us to know that one thing. If you ever counsel a person to stop agonist or partial agonist treatment, there's not a shred of evidence in existence that that's a good decision for your patient. There's not one study that shows that a person does better when they stop the medication than when they're on it. So where are you coming at that person from? Are you coming at them from a harm avoidance approach where you're trying to get them to use the best treatment available? Or is it just part of the cultural bias that we all have kind of been bred up in? It's kind of an American trait to be self-reliant, to not to be dependent on things, and yet the science just doesn't support it. We know that the longer people stay on medication, the more likely they will recover in a very full way. Already, Brandon had put together a life in a few months that was better than anything his parents could remember. So the end of this story, or the continuation of this story, is that he keeps listening to the kind of folks that were supporting him, very well-intentioned folks, people that care a lot about him, and he tapers off his medication. And within a few weeks, he's back out using. And he lost everything he had gotten. His apartment, his job, his friends, his community, and pretty soon he was back in prison again. Now, I can tell you today, 'cause a lot of times I've given this presentation for a long time. I've talked about Brandon, because this was years ago that I first did the interviews, and for a long time I had to end the story like that. Well, it turns out that he's back on buprenorphine, he's out of prison, and he's doing pretty well again. But I have to say this, he's taken a lot, it's taken a real toll on him in the years since that decision was made to stop. Could he have relapsed anyway? Sure. But all signs were that the medication was really working and really helping him. And that, when I first started as a counselor, I really thought that change would happen quickly. I think that's one of our issues as counselors. We're very idealistic. And we want the absolute best for our patients, and we hope in them and we believe in them. And yet when we deal with chronic illnesses like addiction, it can be a slog, and change can happen in a nonlinear way. It's not always that satisfying. I really remember when I first started, I was the young guy, and so they gave me a lot of young folks with heroin addiction, and I thought to myself, I'm going to be able to help all these, but and in 6 months they're all going to be doing well, and at the end of 6 months, I looked back I listed all of the young people, men and women with opioid addiction that I had treated, and every single one of them had relapsed. And I mean, that was my first real, and not only had they relapsed, but they had made my life really difficult because I was always afraid for their survival. And I did in that period lose one client that was very, very close to overdose death. So we have to be patient. We have to be patient with the medication and really just support medical treatment because it's a really core component for managing cravings. We also have to be patient with the fact that the changes that we're looking for might come and they might not come right away. So this patient, David, was a methadone patient. He had been in prison most of his adult life. He was about to go back to prison, had a meeting with his family, his probation officer, and they said, look, you're going to go back to prison, or we were able to get you into a methadone clinic and you can start methadone. And he actually had tried to get into methadone back then. This was a while back, about 12 years ago now. There was a long waiting list and he was having trouble getting in. He says, all right, I'll start today. He went to the methadone clinic, he started, and 12 years later, he's still doing methadone treatment and doing great. But he talks about those first, and he credits it with saving his life. He talks about those first weeks in methadone, or months in methadone treatment, and I talked to his wife too, and she said the same thing. And what was he doing? He was going into his treatment provider, and he was saying, oh, my cravings are so bad. He was trying to get as high a dose as he could possibly get. And then he would drink the dose, and he'd go out, and he would even nod a little bit. He'd get that really warm, fresh feeling, and he said, the words he used was, I was a legal dope fiend. I was using that methadone in a way to just get some relief I'd been using for so long, decades, right? He said, but my counselor, just kept talking to me and wasn't making a big deal of it, just said, keep coming back and getting your dose. And over time, as we talked about my life and talked about what my goals were, I realized that I was getting less and less out of that experience. I didn't really want to be on a dose that was impacting my functioning. And so gradually over time, I collaborated with my counselor until I got onto what they call a blind detoxification, a blind taper. Now, when I knew him, he'd been on a blind taper for years. So he just didn't know what his dose was. Different clinics have different policies about that. But the fact was that he was allowing his providers to taper his medication down to a therapeutic functional level, and he was doing really well on it. And his relationship with his wife was better. Most recently, when I talked to him, he was working. It really had gotten his life back. But sometimes when we see those initial drug-seeking behaviors, when we see that kind of hesitation to change right away, it can make us anxious. But if we're patient with our folks, one of the things that we need to continually believe in is that as people get treatment, the changes that we want them to make will happen over time, on their time. And then finally, a lot of people use drugs. A lot of people use drugs. A lot of people use opioids that never come to treatment. Most of the people that use opioids never come to treatment. And a lot of people that become dependent on opioids never come to treatment. Some of them are even able to quit on their own. The people that come to treatment have the highest levels of complications, co-occurring mental health problems, social determinants that reinforce the addictive problems, and those are our patients, right? The people with the most complications. I have had a client that I've had for years, or I had for years. She actually moved out of state not too long ago, Amelia. And when she came to see me, she grew up in a very abusive household. Her parents, her father was domestic violence against her mother. She was constantly trying to protect the younger children in the family against all the fighting and yelling. She was scared all the time. She was in kind of that protective role. She left home as soon as she could. She started stripping in order to make money, and she was able to support herself and make it that way. And then her her second husband, rescued her from the stripping life, paid for things, and married her, and was himself extremely abusive and manipulative. So she basically lived a life of chronic trauma, and everybody who's working in this field has clients like that, clients who have had chronic trauma histories. So when she came to me, she was in this abusive relationship. She also has a history of anorexia. She was in this abusive relationship. She was drinking to the point of hospitalization. She'd been hospitalized at least 6 or 7 times. She was hospitalized in the time that I treated her in the first few years. She was hospitalized a couple times. And taking a motivational interviewing approach, meeting her where she was at, the first thing I'll say is she was not very treatment compliant. She would not come to groups. Well, if you think about someone who's been through, and she would come to her individual sessions every week, she'd relapse every couple months, she took her medication all right, But if you think about someone with a trauma history like that, why wouldn't she come to groups? Her core beliefs about other people were that they were going to hurt her. Over time, she was able to kind of feel safe enough to come into individual therapy, but she was absolutely terrified of groups. First year goes by, no groups. Moderate success. She had a few relapses, but eventually, got 4 or 5 months of sobriety. During that period, though, she got strong enough to leave her abusive husband. Not the first time. The first time she tried to leave the husband, she had the keys to the new apartment in her hands. She hadn't told him because he would be furious. She left. She was sober for a few months, so she was feeling stronger and really thought she could do this on her own. Had the apartment ready, pulled into a gas station, and drank to such extreme intoxication that he had to come and have her hospitalized. I went to the hospital, met with her and her husband, which was my only alternative, helped her get back into treatment. And then about 6 months later, she tried a second time, and she did it. And she's never been with him since. Well, that's not true. She had one little relapse to him, but she hasn't been seriously with him since. She started working retail jobs, supported herself, et cetera, et cetera. I don't have time to go through her whole history, but it was only after the 3rd or 4th year that she was willing to go to an AA meeting. And the only reason she was willing to go was because she'd made so much progress over time. Sure, she would go to treatment meetings, but she wouldn't talk. Then she would go to treatment meetings, she'd talk. I still remember getting a text message from her the first time she talked because it was such an overwhelmingly positive experience to get people's feedback back from her and reinforcing. She said, I can't believe I wouldn't do this. You were telling me to do this for so long. I couldn't believe I wouldn't do this. And it was a really positive experience. But we have to help patients find security in themselves and in their worlds. Patients that have, a lot of whom have never experienced security in their lives, right? Who are basically like Hattie at this new place in their lives because of all the experiences that they've had. And so I guess I just want to encourage people to be patient and to know that in that process with opioid addiction, being part of a medication-first program where people have medical care through that whole process is the absolute best we can do. So. Is there any time for questions? One question. All right, and this is kind of the end result. When people start to make connections in the world, when they start to overcome those core beliefs they have that impair their sense of security and their sense of belief that they can find security, that's when we really help them find recovery. One question. All right, thanks very much.